An IV will be placed in most patients that walk into a hospital. This is a task that can be completed by PCTs and nurses. There is a lot of skill and knowledge involved in the placement of IV catheters, and this video will demonstrate and explain the basics of placing an IV using the Supercath 5 Safety IV Catheter from Medikit. This information will set you up for success, and once you're armed with that information, it will then be your responsibility to practice and hone your skills until placing IVs becomes second nature.
When does a patient need an IV? In the past, the policy at Trinity Health Livonia was that all patients required IV access. But that's no longer the case. Since the implementation of the vascular access team and the availability of ultrasound-placed IVs and intraosseous access, it is always possible to quickly attain vascular access in the event of an emergency. So now, IV access is only required for patients that are receiving treatment through that device. IVs are used for things such as continuous fluid infusions, medication infusions, IV push medications, receiving contrast for imaging testing, or for continued access for blood samples. If your patient requires any of these measures, or anything else that utilizes IV access, they will likely require an IV to be in place. Peripheral IVs can be placed by PCTs and RNs. The vascular access team is also available to aid in placement, but they should be called only after multiple unit staff members have attempted to place a peripheral IV. The vascular access team is to be utilized to place the difficult IVs, not all IVs. Once you've identified that the patient will require a peripheral IV, supplies will need to be gathered from the pod room. You will need a transparent dressing. The best dressing we have available is the Tegaderm IV Advance, which also functions as a securement device to protect from accidental removals and displacements. But the basic, small, clear Tegaderm is also available in the pod rooms. A blue procedural pad. An appropriately sized IV catheter. Clean gloves. A tourniquet. Tape. A chlorhexidine swab, or if that is not available, alcohol prep pads, sterilely packaged 2x2 gauze, a swab cap, extension tubing, and 2 saline flushes.
Before you begin, you should understand some of the equipment. The catheter used at Trinity Health Livonia is the Supercath 5 by Medikit. It is stocked in 3 common sizes. The size is printed on the package, but they are also color-coded. Blue is a 22 gauge, pink is a 20 gauge, and green is an 18. The larger the number, the smaller the diameter of the catheter, so the 22 gauge is the smallest, and the 18 gauge is the largest. The Supercath is packaged with a protective cover over the needle. Remove it to reveal the needle, a white button, and the grip area of the device. Behind the button is a textured grip on either side. I hold the needle with my thumb and middle finger on the grips, leaving my pointer finger resting on top, free to slide the catheter in and press the button to retract the needle. This is my technique. But there is no right way to hold the needle. Find what works best for you.
The needle is hollow and beveled. This means that the tip is cut at an angle, resulting in one side being longer and providing the sharp point, and the other side that extends the angle is the bevel. Whenever inserting an IV, the needle must be bevel up. The point should be on the bottom and the angle on the top. This is easily achieved if you look at the white button on the handle. The white button is in line with the bevel, so if the button is on the top, the needle is positioned bevel up.
The catheter itself is not the needle. It is over the needle. The catheter is a flexible tubing attached to the colored hub, and this is what will remain in the patient after placement. The actual needle will be removed. Because these are 2 separate pieces, it is important to make sure that the catheter is properly seated on the needle before poking the patient. The company recommends you rotate the catheter around the needle until you feel it seat into place. When it is in the correct position, you can see a small raised ledge on the top of the catheter hub. This should be on the top of the catheter, and you will use it to thread the catheter off the needle once you've accessed the vein. Behind the needle, there is the white button. This is how you activate the needle retraction. It is a safety feature to protect from accidental needle sticks. Once the catheter is in place in the vein, you will press the white button and the needle will instantly be pulled back into the handle of the device. With the needle removed, you can see more clearly through the colored hub. The Supercath's catheter hub contains a temporary valve that serves to stop the flow of blood through the catheter after the needle is removed. This is in contrast to other commonly seen devices that lack this feature. With the Supercath, once you've retracted the needle, blood flow is stopped by this valve, preventing unnecessary blood loss and allowing you time to smoothly complete your insertion steps without making a mess.
Now that you have your supplies, you will need to locate a good site to access. And to set yourself up to find the best site, you want to engorge those veins with blood so that they are easy to see and feel. Do this by first placing the tourniquet. Tourniquet should be reasonably tight. They need to impede the flow of blood so that the veins swell slightly. To place the tourniquet, slide it under the patient's arm, then stretch it up and cross the two sides. Hold them together with one hand, and with your other pointer finger, push the middle of one of the ends of the tourniquet under the part that is squeezing the arm. Do not put the tail end of the tourniquet under, because that will be difficult to remove. What we want to do is to create a slip knot that is easily undone by pulling on one of the tails. So when you are done, both tails should be pointing in the same direction from the tourniquet. Pointing in the opposite direction should only be the loop. The tourniquet should be tight, not so tight as to cause pain, but it should be slightly uncomfortable. If they can't feel it, it probably isn't doing its job. It is acceptable to tie the tourniquet over the sleeve of the gown so that the rubber material doesn't pinch the skin, but this is clinician and patient preference. A tourniquet should only be in place for 1 minute or less. If after a minute you have not located a vessel, untie the tourniquet. You can check the other arm at this point, or wait 1 to 2 minutes before retying the tourniquet to continue looking on that arm. If tied correctly, the tourniquet is easily removed. Just pull on the tail end that created the slip knot loop, and the knot will release, effectively popping the tourniquet off. With the veins swelling with blood, locate a site. There are 2 main strategies for site location. Some people look for veins, as in with their eyes. Sometimes veins will bulge out of the skin and you can see them easily, and other times people will look for the bluish tinged outline of a vein beneath the skin. Others will look for a vein with their fingers, gently running their fingers over the patient's arm to feel the vessels. Vessels will feel like a slight bump in the arm, and if you press on it, the vein should be spongy and rebound to its original shape after you release pressure. If the bump you feel is hard, it could be a tendon or ligament, or it could be a vein that has developed a lot of scar tissue. Even if it is a vein, this is not an ideal site. Veins with scar tissue will be more difficult to access, and their integrity is already compromised from previous damage. Find a location that gives that spongy feeling, and you'll be more likely to have a successful, long-lasting IV. Also keep in mind, people's bodies are generally built the same way. There will be variations from person to person, but the main veins are going to be in the same general location for each person. You can look at mapped out pictures showing all the names and locations, but through practice you will probably find your favorite veins. What are you looking for in a vein? A good vein is important. Larger is better, and you'll need a stretch of vein that is straight for the length of your catheter. The catheter won't be able to bend around corners in a vein, so you need to choose a location that allows for it to slide completely in and remain straight. So where are the best places to place an IV? You've probably seen a lot of IVs placed in the AC. This is inside the bend of the elbow. There's a nice big vein here, and that's why it's always a very common placement, but it is not ideal for a patient laying in bed all day. It's uncomfortable, and every time the patient bends the elbow, it will kink the catheter and impede the flow of fluid or medication through the IV. In general, try to avoid placing IVs in joints for this reason, so wrists shouldn't be a first choice either. Another reason wrists are not ideal is the presence of nerves, tendons, ligaments, etc. On the underside of the wrist is usually a very visible vein, but this location tends to be problematic and painful because of the joint and the pressure the catheter can put on the other structures in this area. But if you trace that vein further up the arm, you may find a much better site. There are usually some visible veins in the hand, and while these are good for lab draws, they aren't ideal for IV placement. Even if you successfully avoid being near any knuckles or wrist joints, it will still likely have issues. People use their hands for a lot of things, meaning lots of movement. More movement means more likelihood of the IV being dislodged. Also, because of where hands go, they get dirty really easily, which increases the risk for infection. And they tend to be more sensitive and painful in general, so hands aren't a first choice for placement either. Arguably, the best locations are in the forearm. There are plenty of large, straight veins and no joints. Do a thorough search for veins in the forearm. Look on the top. Look on the bottom. And move the arm around at different angles, and you may reveal some excellent untapped veins. While forearms are arguably the best option, the other sites mentioned are also viable options for placement. But as discussed, they come with more potential drawbacks and issues, so choose your locations carefully. If you don't see something you feel like you can successfully place on the first arm, look on the other arm. Take your time. The biggest mistake people make when placing an IV is rushing while looking for their right vein. If you take your time and find the best vein, your chances of success will skyrocket. Once you've located a site, find a way to mark it, or make note of where the vessel is. You can use a sterile body marking pin to trace the vessel, or use freckles, moles, scars, or other landmarks to remember the location. Because after the site is found, you need to remove that tourniquet, and you may lose visualization of the vessel. In some cases, you will be able to look on either arm to find the best site, wherever it may be. But with a lot of patients, there will be some limitations to where you can place an IV. If a patient has had lymphedema in the past or breast surgery with lymph node removal, you cannot place an IV in the affected arm. If the patient is a dialysis patient with an AV fistula in an arm, you cannot place an IV in that arm. If the patient is a renal patient in any respect, even if they are not currently requiring dialysis, avoid placing IVs in the AC. If the vessels in this area are damaged from numerous IV placements and lab draws, it can cause significant problems if they need to place an AV fistula for dialysis access in the future, and that could be the difference between life and death for a renal patient. Only the vascular access team is allowed to place IVs in the lower limbs. If the upper limbs are unusable, there are many factors that will come into play to choose a different access device or potentially place a peripheral IV in the legs or feet, and the vascular access team will assess the patient's needs in these cases. Be aware of these and any other limitations to site selection that your patient may have before accessing a vessel. Once you've located an appropriate site for your patient's needs, choose the correct gauge needle. As previously stated, 22 gauge, 20 gauge, and 18 gauge catheters are commonly stocked in the unit pod rooms. 22 gauge is the smallest and 18 gauge is the largest. There are a few factors that come into play. The larger the catheter diameter, the faster fluids or medication can be delivered into the vein. Smaller diameter catheters will restrict the speed of delivery. Also take into account the size of the vessel in which you will be placing the catheter. In general, the further down the arm, the smaller the vessel. Smaller vessels mean less blood flows through the vein every minute, and flowing blood is what carries the fluids or medication back to the heart to be dispersed through the body. When you insert a catheter into a vessel, it will occlude part of that vessel, but you still need blood to be able to flow through the vein to carry that treatment to the heart. There is a common misconception that bigger catheters are always better, but bigger catheters will occlude more of the vessel, and if the vessel can't handle that size, blood flow could be severely impacted, along with medication delivery. For most general treatments for adults, 22 gauge or 20 gauge catheters will be appropriate and result in less vessel occlusion. 18 gauge is only really necessary with large volumes of fluid or medication that must be infused at rapid rates. Also, the larger the catheter, the more damage will be done to the vessel, and the less likely your IV is going to last. So to give your IV the best shot at lasting a long time, a good principle to follow is to insert the smallest gauge necessary for treatment into the largest vein available. With your site and catheter chosen, it's time to get to work. Use the chlorhexidine swab to clean the site. Chlorhexidine swabs can clean 1 square inch for every milliliter of fluid in the swab. This swab holds 1.5 milliliters, so it only disinfects 1.5 square inches, which means you clean your site, not the entire arm, with this swab. Disinfect by vigorously scrubbing the site back and forth for 30 seconds. Then you need to allow time for the CHG to fully dry. This gives you time to set up the rest of your supplies. Open the Tegaderm package, but don't do anything else with the dressing just yet. Open your sterile 2x2s and make them easily accessible. Open the catheter and the swab cap as well. Then take a look at the extension tubing. On one end is the adapter that will insert into the catheter hub, and on the other end is the needleless port that you would insert a syringe into if you were administering something through the IV. Open the package from this end, but don't open it completely. And don't remove the tubing, just expose the port. Then attach a saline flush and prime the tubing. We keep the tubing in the package so that it can act as a reservoir for the extra saline you push out the end as you prime. Keep the tubing in the package for now, to protect it from unnecessary contamination, and lay it with the other supplies. Return to your patient. Ensure the site is dry before continuing. If it isn't, it can lead to increased pain with insertion, and if the dressing is placed over chlorhexidine that isn't dry, it can cause a painful, itchy rash to develop. If the site is dry, retie the tourniquet. The area that you disinfected is now a no-touch zone. You cannot touch this area, or it will become contaminated, and you will need to disinfect it again before inserting the catheter. You can touch above or below the disinfected area, though. You can anchor the vessel in place by putting downward pressure on the vessel below the disinfected area. This can keep the vessel from rolling when you insert the needle. Always insert IVs aiming up the arm, never down toward the hand. Inserting down the arm leads to increased risk of clot formation, as well as poor delivery of medication from the catheter. Take the catheter and angle the needle about 15 to 30 degrees to the patient's skin. Any steeper and you will likely poke through the opposite side of the vessel very quickly. Any shallower, and the point of the needle may not be able to enter the vessel. Line the catheter up with the vessel. Poke the patient. As soon as the needle enters the vessel, you will notice blood filling the handle, and probably also the catheter itself. but with some gauges, the blood isn't visible in the catheter. This blood is called the flash. When you see the flash, it means that the needle has entered the vessel. Stop inserting when you see the flash. Take a breath. The first big step is done. Next, you need to ensure that the catheter itself has also entered the vessel. The needle extends further than the catheter, so the flash will come before the catheter is actually in the vessel. You'll need to advance the needle and catheter a bit further, but before you do that, adjust the entry angle. Lower the catheter angle to become closer to parallel with the vessel. When you slide the catheter off of the needle, you want it to be able to slide in along the length of the vessel. If the entry angle is too steep, the catheter may get stuck on the opposite wall of the vessel as you try to thread it in, and this will impede the insertion. With the angle adjusted, just advance the needle another 1 to 2 millimeters. Then stop again. Now the catheter should be solidly inside of the vessel. Next, we are going to advance the catheter off of the needle and into the vein. And if you don't have the catheter in the vein already when you do this, you could damage the vessel as you forcefully push the catheter in, and that can cause the vein to leak, leading to hematoma and an unusable IV. So to recap the steps, first, poke through the skin and advance until you see the flash. Then, lower the catheter angle and advance 1 to 2 millimeters further. Thirdly, only after advancing that additional 1 to 2 millimeters, slide the catheter off the needle until the colored hub reaches the skin. Remember that small raised ledge on the catheter hub? Use your pointer finger and push the hub off of the needle using that ledge for leverage. While you are doing this, hold the needle steady. You are not advancing the needle, only sliding the catheter off of it. The needle provides a rigid structure to guide the catheter into the vein. A common mistake is for people to retract the needle after they have the catheter trip in the vein. But when you do that, the rigid guide is lost, and you will have issues if you try to push the flexible catheter into the vein at that point. Another common mistake is to advance the needle with the catheter all the way. When you do this, you will most likely poke through the bottom of the vein. Now the IV is not usable because it's not inside the vessel. You will see no blood return, and if the IV flushes at all, it will cause a lump to form because the fluid isn't traveling in the vein, it's being deposited in the subcutaneous tissue. After you have appropriately guided the catheter off of the needle, slide the 2x2 gauze under the catheter hub to catch any drops of blood. Then depress the white button to activate the needle retraction. You do not need to remove the needle from the catheter first. You should push the white button while the needle is still in the catheter. Once that needle enters the arm, there is no reason you should ever see the tip of that needle again. Retracting the needle at this point eliminates any risk of an accidental needle poke with a dirty needle. When the needle is removed, the temporary valve should stop or at least significantly slow the flow of blood from the catheter. At most, you may see a few drops of blood that will be caught by the gauze. Then take the primed extension tubing. There is a white cap on the end of the tubing. Remove it and attach the tubing to the catheter hub. Twist it clockwise to tighten it over the hub. Remove the tourniquet. Pull back on the syringe to check for blood return. You should get blood return. It means that your catheter is still located in the vein. Then flush the blood back into the IV. You want to clear all blood from the tubing. If you accidentally pulled blood into the syringe, grab that second saline flush and flush with a clean syringe of saline. That way you won't be flushing with a mix of saline and blood, and you can be sure that your line is clear when you are finished. Remove the 2x2s. If there is any blood on the arm, take the time to clean that up before dressing the IV. The Tegaderm IV Advance is available in the pod rooms at Trinity Health Livonia. It functions not only as a line dressing, but also as a very effective securement device to protect against accidental dislodgement or removal. It can be used on all forms of vascular access devices. The dressing consists of 3 parts. They are nicknamed the shirt, the pants, and the belt. They are all connected when you start, and you will separate them as you place the dressing. The shirt is the center of the dressing, and the largest piece. It contains a transparent window in the center surrounded by a more rigid material, and at the bottom of it is a slit. The window should cover the access site completely. You should be able to view the insertion site and the catheter hub easily. Place the shirt positioned to show this, and make sure the slit is pointed down the arm in the same direction as the extension tubing. Gently lay the shirt over the access site. Do not stretch it tight as you place the dressing, because this will put unnecessary pressure on the catheter that can lead to the development of pressure injury. Just lay it over the site and push it down with your hands to make sure it fully adheres to the skin. The extension tubing should line up with the slit at the bottom of the shirt. Once it is in position, push the 2 pieces of the slit down onto the skin so that the extension tubing is left exiting the dressing from the small hole created about 3/4 of an inch from the edge. Remove the paper frame from the shirt. This will separate the pants and the belt from the shirt. Next, we'll put on the pants. They are made of the same material as the outside piece of the shirt. It is more durable than the transparent window. There is a small U-shaped opening on the pants, and there are also 2 paper tabs on the corners that remain after you peel it away from the paper frame. These are there for you to hold and to avoid the pants sticking to your gloves. You're going to tuck the shirt into the pants, which means the pants will overlap the bottom of the shirt piece. Lift the extension tubing and slide the pants so that the U-shaped opening surrounds the extension tubing, similar to how the tubing sat between the opening of the slit on the shirt. Smooth the pants down, and then remove the paper corners, and gently press the pants down completely. At this point, you should close the slide clamp over the extension tubing. Whenever the IV is not in use, the slide clamp should be closed. With the saline syringe still attached, slide the clamp so that the tubing is pinched and occluded. This is often ignored or skipped, and it will lead to clotting off of the end of the IV in the vein, and ultimately a decreased lifespan of the IV. If you don't close the clamp, when you remove the syringe from the port, it will create a small amount of negative pressure in the catheter, because the space occupied by the tip of the syringe will be backfilled by saline. At the end of the catheter that is in the blood, this will cause a concave opening to form as the saline retracts into the catheter. This opening will be filled with blood. That blood will become stagnant as it sits in the opening and no longer flows with the current of blood. It won't take long for that blood to begin to clot, which can occlude the catheter and make it unusable. If before you remove that syringe from the end of the IV, you slide the clamp closed, you create positive pressure in the IV. This creates a convex protective bubble of saline at the end of the catheter. Blood is not able to sit on the end of the catheter and instead is constantly moving with the flow of blood, which means it never has a chance to clot on the end of the catheter. This leads to significantly extended lifespan of your IV catheter. At this point, you should also apply the swab cap to the end of the extension tubing by firmly pressing it over the port. Anytime the IV port is not connected to a syringe or infusion, all ports should be covered with an orange swab cap. The swab cap contains a sponge impregnated with alcohol that protects the end of the catheter from contamination and bathes it in disinfecting alcohol. Finally, it is time to apply the belt. There is space on this piece to time, date, and initial the dressing, and make sure that you do this at this point. Then place the belt overlapping the shirt and the pants where they meet. The belt can also be used to position and hold the extension tubing so that it is directed up the arm, or you could choose to use tape to position the tubing. When the IV advance is placed correctly, it does an excellent job of protecting the IV from accidental dislodgement. It can be pulled on with a lot of force and still remains in place. Obviously, if someone really wants to pull out their IV, this won't stop them, but it does stop the vast majority of accidents from ruining a good IV. The other dressing option available is the standard Tegaderm dressing. This is a simple, small, transparent adhesive dressing that is commonly used to protect IVs after placement. After your IV is in place, peel the backing off the Tegaderm and lay it over the access site. You want to completely cover the catheter hub and the connection where the extension tubing and the catheter join. Peel off the paper frame from the dressing. There is a label attached to the frame. Time, date, and initial this label and place it directly on the Tegaderm. You'll need tape to further secure and position the IV and tubing. Silk tape and paper tape are stocked in the pod rooms. Paper tape tends to cause less irritation to the skin in some patients, but does not adhere quite as well as the silk tape. Tape also comes in different widths, and silk tape is easily torn in half to get to your desired width. I personally prefer to use thinner strips of tape for my dressings. One common practice is to prep the tape before applying the dressing and stick it to a nearby table or bed rail until you need it. This is not best practice. It introduces a potential infection risk to the insertion site you just created. Tape is sticky, and by prepping in this way, it is stuck to a non-sterile, probably dirty surface, and then carried over and applied very near to a hole in the skin that gives direct access to a vein. Infections can lead to a loss of IV access, and that's really a best-case scenario because infections that have a direct line to a vein can quickly lead to life-threatening issues. So unroll your tape as you need it, and use it to secure and position your catheter's tubing. Most people will place a strip of tape along the bottom of the Tegaderm, and then at least one more to position the tubing so it's pointing up the arm. This position can help protect your IV, because if the IV tubing is attached and gets pulled on, it won't be pulling the catheter straight out of the arm, but will instead be pulling in the opposite direction. When you're satisfied with your tape, flush the catheter, close the slide clamp, detach the flush, and apply a swab cap. The standard Tegaderm does little to secure the IV, which is why the IV Advanced is such a useful tool to have. Pulling on the IV Advanced requires a lot of force to dislodge the catheter from the arm, but it doesn't take as much effort to lose access with a standard Tegaderm. With the IV in place and the dressing protecting it, you have successfully completed the IV insertion. Chart your IV placement in Epic using the avatar. So how long can it stay in? At Trinity Health Livonia, an IV can stay in place as long as it is free from signs of infection and it is still functioning properly. If you take care of an IV, flushing regularly, and always closing the slide clamp, IVs can last weeks. However, the dressing will need to be changed more regularly. If it ever becomes soiled or is starting to peel up, it should be replaced. It also must be replaced at least every 7 days. This is why timing and dating the dressing is so important. If you can't figure out when a dressing was placed, it needs to be replaced during your shift, and make sure you time and date the new dressing and chart the dressing change in Epic. Put all the used catheters in the sharps container. All other garbage can be in the trash or biohazard bin. IVs will need to be removed eventually. Sometimes an IV will go bad and no longer function properly. In that case, we want the non-functioning IV removed immediately. You never want to risk someone attempting to give medications through a non-functioning IV. Other times, the IV may no longer be needed. Either IV treatment is complete or the patient is being discharged. Whatever the reason, the steps to remove an IV will be the same, and it's a relatively straightforward process. Begin by collecting your supplies. You'll need alcohol swabs, or chlorhexidine swabs would work as well, tape, and a small stack of 2x2 gauze pads. The first step is to remove the adhesive dressing. This is arguably a more painful experience than placing the IV, so take some time to make this as painless as possible. Take an alcohol swab or chlorhexidine swab. Peel a corner of the dressing up and scrub under the dressing with the swab as you lift up on the dressing. It will help to neutralize the adhesive and allow the dressing to lift off the patient more easily, without pulling as much on the skin or hair. When you get close to the catheter site, peel up all sides surrounding the catheter, but be careful not to pull out the catheter just yet. This example shows the IV advanced dressing, but removing with alcohol helps with the removal of most adhesive IV dressings. Once you've got the dressing up, step 2 is to take the gauze pads and fold them twice down the center to make a small square of folded gauze. This will act as a pressure dressing when taped over the IV site. Then get an appropriate length of tape ready. Hold the gauze over the entrance site and smoothly pull the catheter out. Press the gauze down and tape it in place. You have successfully removed the IV. There will likely be some bleeding from the site following removal, and the dressing should remain in place until bleeding has stopped. It shouldn't take too long, but in general, if you wait an hour, the dressing should be able to be removed, and patients being discharged should be told that information as well. The placement of IVs is something that will need to be completed for most patients at Trinity Health Livonia. It can be done by PCTs and RNs. It is a skill that requires practice, so take the opportunities when they come, and don't be discouraged by failed attempts. Learn from them. Get better with every attempt, and eventually you will master the skill. It will save you time and hassle, and your patients will appreciate your dedication.